Hello and welcome to today's Medcan online seminar. My name is Tanya Haas and I am the in-house health and wellness writer here at Medcan. Today's online seminar is titled Gut Feelings, Expert Insight on Gastrointestinal Health with Dr. Linda Lee from Johns Hopkins School of Medicine. Now, before I introduce our presenter, there are a few housekeeping items to cover. This presentation is being recorded and will be made available at medcan.com under Medcan Insights in a few weeks. There is the option to join us by audio, which we hope you're doing. If you've had trouble,
Hello? What should I do?
to the screen in your screen that looks like this. There's a little question and answer section. So feel free to write your questions throughout the presentation. And at the end, if we have time, we will address a few of the submitted questions. We also asked our participants to send email questions, and we did receive them. So thank you so much. The presenters and the people who ask the questions will remain anonymous, but unfortunately we may not be able to address all the questions in the time we have today. And finally, the information in this seminar is for educational and information purposes only and is neither intended to be relied upon nor to be a substitute for professional medical advice, diagnosis, or treatment. Now, with all that being said, I have the great privilege of introducing our presenter today, who is joining us from Baltimore. Dr. Linda Lee. She is the founder and director of Johns Hopkins Integrative Medicine and Digestive Center, which is located just outside of Baltimore. She is also the clinical director for the Johns Hopkins Division of Gastroenterology and Hepatology and the director of endoscopy for Johns Hopkins Hospital. Dr. Lee has been involved in gastrointestinal and cancer research, teaching, and clinical care, and she lectures frequently in the community and to medical students and practitioner. In addition, she is a fellow of the American Gastroenterological Association and the administrative editor for practical reviews in gastroenterology. She's also created specific programs that have developed targeting cancer patients and survivors, as well as women with digestive health issues. She has a lot more in her CV, but let's get to the meat of this seminar, and we're so honored to have you join us, Dr. Lee. Thank you.
Thank you so much, Tanya, and I want to thank all of your colleagues there at Medcan and my colleagues here at Johns Hopkins International for arranging this webinar this evening. And thank you to every one of you who has actually dialed in to hear this. I hope it's helpful information to you, and as Tanya said, I'm very happy to answer any questions you might have at the very end. All right, so with that, shall we get to the next slide? Am I controlling it?
Yes, you should be able to.
It's not going. So
all
maybe,
right.
Okay.
No problem.
Sorry about that.
No problem. Here we go.
All right. Well, I thought I would first just give a little bit of background before we launch into a discussion of the good bacteria in our guts. What I wanted to talk about a little bit first is what modern medicine is all about. And as we all know, modern medicine today is based on a molecular and biological understanding of disease, with the goal of finding what we call evidence-based therapies. This kind of approach has led to the discovery of so many different kinds of drugs and has advanced medical technology. But one of the challenges we face is that with all these therapies, and by virtue of the approach that we've taken, these therapies often are not individualized, meaning that they don't really take into account that we as human beings are not completely identical, and how we respond to disease and how we respond to treatment can really vary. This is where precision medicine comes along. Many of you may have heard this term, precision medicine. So what is this? Well, precision medicine promises the customization of healthcare, with medical decisions, practices, or products being tailored to the individual person. And how we do that is we use various tools, which can include molecular diagnostics, imaging, and what we call analytics. Now, what does that mean? What does it boil down to? It means basically using DNA at this point. Even at Johns Hopkins, we're very excited to launch 8 precision medicine centers of excellence. These are based in a variety of disorders, including prostate cancer and cardiac arrhythmias. And so the notion is that individuals who have these diagnoses can be investigated to determine what individual characteristics affects the state of their disease and also might actually predict the response to therapy. So sequencing your DNA, that was what I was referring to. This has really been sort of the mainstay of precision medicine. And many of you may have heard that you can get your DNA sequenced by various companies that are out there. And getting your DNA sequenced can give you some really interesting information. So if you have any questions about what your ancestry might be, this might be a good way to approach that question. And you can see an example of what someone's readout was based on their DNA sequencing. And they can see sort of what their ancestral makeup is. On the right side, you can see that it can even tell you how much Neanderthal DNA that a person has. And I was very interested to learn that people of Eastern Asian descent are more likely to have more Neanderthal DNA than Europeans, for example. So, of course, that affected me because I think you may have seen my picture at the front. I am of Asian descent, so I'm wondering what part of me is the Neanderthal, but I don't ask my husband about that. Anyway, let's go on. Next slide. So sequencing your DNA might be able to tell you about a lot of different things, not just your ancestry. So for example, it can tell you about specific inherited physical traits, and also may give you a little bit of information about your susceptibility to specific diseases. Today, DNA sequencing is often employed, next please, to determine responsiveness to certain drugs, because we know that individuals metabolize medications at different rates and in different ways. And so that can affect whether or not one person might respond to a certain drug versus another person. And it also can help us predict which individuals might be sensitive to side effects caused by certain medications. So today, that's how DNA is being used. DNA is also being used in cancer care. And nowadays, if a person is found, unfortunately, to have cancer, that person's cancer cells can be isolated and the DNA studied to identify what unique proteins that particular person's cancer makes. And then what can happen is, using that unique information, decide if there is some specific kind of chemotherapy that person's cancer cells are going to respond to that maybe someone else's cancer, even if they have the same kind of cancer, may not respond to. So this has really allowed better treatment of certain types of cancers. In my world, as a gastroenterologist, we can look at a person's DNA to see if they have genes that cause them to be slow metabolizers of a specific drug. So this way we can adjust the dosage of the drug to reduce the risk of causing liver toxicity, meaning injury to their liver. So again, this is another way how precision medicine is being used today. What precision medicine to this point has ignored is the fact that there is more to us than the DNA that's within our cells, believe it or not. So this is a drawing of what our gastrointestinal tract looks like. All of you may not be gastroenterologists out there, but I thought I would just orient you a little bit. When we eat, food comes down through our mouth and down this pipe called the esophagus. And the food then ultimately ends up in the stomach, which is pointed out there. The stomach grinds the food into small little tiny particles over the next couple of hours, and then with one big muscular contraction pushes all that food down into the small intestine, which is about 20 feet long, and that's where we absorb all our nutrients. Whatever we don't absorb there, be it nutrients or be it digestive juices or whatever other things that we eat that our body doesn't need, will ultimately be eliminated into our large intestine, or the colon that's there, and stored until we're ready to eliminate it completely. So this is just a diagram of the GI tract, and I wanted to point this out because it's in the colon where we now know we have trillions of bacteria, and within all those bacteria there are twice as many bacterial genes as there are human genes in our body. So this is really astounding, because what we're recognizing is that our health our well-being isn't simply just determined by our DNA, but also perhaps by the genes that are within the 100 trillion bacteria that live inside the large intestine. So you're going to hear some terms. Oh, can you go back for a second? You're going to hear some terms that are often used to discuss the bacteria, the 100 trillion bacteria that are in the colon. We call them collectively the microbiota, so that refers to the different types of bacteria that are present in your colon. You have many different types, maybe 5,000 different types. And microbiome actually refers to the genes that are encoded in the DNA of all those bacteria. So those are two very commonly used terms that you will see in the literature in the lay press. Okay, next. So these bacteria, you know, we all have grown up during a time when we learned that bacteria are really bad for us, right? This is why we take antibiotics when we worry that we have a bacterial infection. But it turns out that these bacteria in our intestines are really beneficial to us. So why are they there? Well, they produce substances that prevent harmful organisms from adhering and invading our bodies. So you can imagine every day we're eating food off plates that we think are clean, but actually there's a lot of bacteria everywhere that we're constantly eating. And of course, some of that bacteria may not be the friendly kind. And so it's good that we have our own community of bacteria that help prevent any kind of bad bacteria from really invading our bodies and making us sick. These gut bacteria, our communities, they improve the intestinal barrier, the lining, by producing a substance called short-chain fatty acids by fermenting fiber that we eat in the diet. So in this way, in some ways, the bacteria in our colons have a symbiotic relationship with our cells because they're producing these nutrients, short-chain fatty acids, for our intestinal lining cells. These bacteria also make products that influence the development and normal function of our body's immune system. There are plenty of studies that have shown that if you were to have a sterile colon from the time you were born to where you are right now, your immune system would not function normally. It would not have developed normally. So we need these bacteria for the proper development of a normal immune system. So how did those bacteria get there? Well, right now, each of us has about 1 kilogram of bacteria living in our colons. Hard to believe, right? So, but when we were born actually with a sterile colon, meaning that there were no bacteria in there at all, until we popped out of our mother's uterus, either by C-section or by vaginal delivery. And the minute we popped out, we began to be colonized by our mother's bacteria. So our mothers really, really had a big impact on our gut community. So you can thank your mom for that. And how our gut bacterial communities get shaped are not just simply by the mode of delivery, but also whether we were breastfed or formula fed. Now, going one step backwards, how did your mother's bacteria become the way it was? Well, of course, her mother influenced the development of her own gut bacterial community, but whether she grew up in a rural area or an urban environment, that would have been a determinant as to what bacteria actually ended up living in her intestine as she got older. Probably the most important determinant, can you go back for a second? Probably the most important determinant of the bacteria in the gut, however, is diet. So whether your mom ate a more vegetarian diet, ate a lot of red meat, or ate a lot of fiber, that all played a very important role in shaping your mother's bacterial community. All right, now next. So what constitutes a healthy community? Well, just like the communities in which we live in our cities, for example, the more populated, the more diverse, and the more productive our bacterial communities are, the more beneficial they are to us as human beings. So I like to use this analogy because it's sort of visual. So as you can see, here's a picture of what, a city community might look like, a healthy one. Next. So patients sometimes will ask me, is there ever a situation when there are too many bacteria in the gut? And that really very, very seldom happens. There is a situation, however, where some people can get too many bacteria in the wrong place in their gastrointestinal tract. As I said, in healthy individuals, most of the bacteria in our guts are found in the large intestine. We have relatively few bacteria in the small intestine. However, in people who have had surgery where their intestines were rerouted, for example, they sometimes are at risk for getting too many bacteria in the small intestine. And that's usually because the mechanisms that the body has to keep the bacterial counts low in the small intestine have been disrupted. So these individuals who get this overgrowth of bacteria in the small intestine sometimes will experience symptoms of bloating, occasional diarrhea, and sometimes more drastic symptoms such as weight loss and even nutritional deficiencies. This condition is called SIBO, which stands for small intestinal bacterial overgrowth. And you will find that term all over the internet. And it's used in a way that makes people think that it's actually a disease. But it really isn't a disease. In most cases, when it's being used on the internet, they're really referring to the symptoms of bloating, maybe sometimes diarrhea. But it's really not a disease per se the way it's being used on the internet. We believe that small intestinal bacterial overgrowth, even though it does exist, is probably not as common as is popularly believed. So what constitutes an unhealthy bacterial community? Well, just like an urban environment where you don't have anybody living there and you have a lot of vacancies, there's a lack of diversity. This is what we find associated with many disorders, many illnesses, that there is a relative lack of diversity of bacterial community members, and there are maybe not as many bacteria as there ought to be. So the problem is that when we have such vacancies, we can have less friendly elements moving in. So just like in a neighborhood, when you've got such a vacant neighborhood in a city, you can have gangs moving in, for example, and causing problems. Well, the analogy in the gut is that you can have bad bacteria or fungi or sometimes even viruses move in and make us develop symptoms or make us sick. And we call this intestinal dysbiosis. So intestinal dysbiosis, where the gut bacterial community is relatively unhealthy, has been linked to all kinds of diagnoses, including chronic gastrointestinal disorders such as inflammatory bowel disease, irritable bowel syndrome, and liver disease. It's also been associated with obesity and with having psychiatric illness and having cardiovascular disease and allergic disorders and so much more. What remains to be determined is sort of a chicken and egg thing. Which came first? The disorder followed by the development of intestinal dysbiosis, or intestinal dysbiosis leading to the disorder? And that remains to be figured out in many, many cases. So often patients are very concerned that they might develop intestinal dysbiosis. And you're at risk for developing intestinal dysbiosis if, for example, you take antibiotics. So we know that if you were to go to the dentist and the dentist says, I want you to take an antibiotic because you have an abscess, a tooth abscess, that when you take the antibiotic, not only does the antibiotic affect the tooth abscess but make it and try to heal it, unfortunately, it does affect your bacterial community in your colon so that you could have relatively less diversity. For most healthy individuals, within 2 weeks, and certainly by 4 weeks of finishing the antibiotic, many of our bacterial community members come home and we've regained our diversity again. But some people don't. For whatever reasons, for reasons we still don't understand, but this is being investigated, these individuals continue to have a lack of diversity. And when they do that, as I said, bad elements can sometimes move in. So the question is, how do you treat intestinal dysbiosis if you think that is the cause of your problems? Well, there are various ways. People have tried using antibiotics with the thought as, well, you know, my gut bacterial community is kind of screwed up already, so I'm just going to blast it with more antibiotics, and maybe after the fallout it will be in a better state than what it was before. Some people will take probiotics, which I'm going to talk about next. Some people have talked about fecal transplant, and some people have talked about diet. So I'm going to touch on each of these things in our remaining time. So the first category is probiotics. So what are probiotics? Probiotics are organisms that we basically think are beneficial to our health. That's exactly how they're defined. Probiotics are generally bacterial strains that are thought to be very safe, and currently they're available in many, many different forms. These can be purchased over the counter as a nutritional supplement, as in the form of pills or powders. They can also be found in naturally fermented foods, and I've shown some of the very popular ones here, like kombucha and kimchi and sauerkraut. So probiotics are available all over the place, but it's important to recognize that when they're sold as supplements, they are not regulated, at least here in the United States, by the Food and Drug Administration, and they are considered as a food supplement and not as a medication. So there are some probiotic strains that out there that have been shown to improve the symptoms in some disorders, and these are based on clinical trials that have been done. So I want to just mention that when you go to the store and are contemplating a probiotic, you will find that you will see tens, if not hundreds of them, and especially if you go to the internet. And the problem is that they are not all the same, because each one contains different strains of bacteria, which theoretically could do different things. The problem is that many strains haven't been tested for specific use, and so most of them are just simply out there as a food supplement. So for most consumers, it's really hard to know which is the right probiotic strain to take if you feel compelled to take one. But here's some guidance from studies that have been done. These are some diagnoses where probiotics were actually tried and tested and shown to be of modest benefit. So for example, children with virally caused diarrhea may benefit from acidophilus or Lactobacillus GG. There have been studies looking at antibiotic-associated diarrhea, recurrent C. difficile diarrhea, traveler's diarrhea, mild to moderate ulcerative colitis, bloating and irritable bowel syndrome, and even atopic dermatitis. So when I have patients who ask me which probiotic should I recommend to them, I first ask them, what do they want to take it for? And if they want to take it for one of these specific reasons, I might direct them to one of those probiotic strains that are listed here, only because there is some evidence to show its efficacy. However, go to the next slide. What has not been shown is whether or not taking a probiotic in a food is definitely beneficial. So patients will ask me, well, instead of buying a probiotic, I'm just going to eat yogurt. Well, one of the challenges with yogurt is that yogurt, which is made by fermenting milk with two bacterial strains, which are shown, can you click on that, right, Streptococcus thermophilus and Lactobacillus bulgarius, those are the bacterial strains that are used purposefully to ferment milk to create yogurt. But the problem is that they don't really meet the definition of being a probiotic strain, because it's not clear that these two strains actually survive the whole process of digestion to actually have any impact in the colon. Now, in contrast, you can find bacterial strains in other fermented foods and cured meats and cheeses, and these do appear to survive digestion, and some of these are shown here. But just because these foods contain probiotic strains, eating large quantities of them may not actually be good for you for other health reasons, right? I mean, yes, I like cheese, but again, cheese is full of fat. And so this is something that, despite the fact that it contains a probiotic strain, it may not be something that I want to eat large quantities of, just because of the calories and the fat that is associated with eating a large amount. So I just want to point out, too, that yogurt seems to, you have to be careful with yogurts, because this is just to show you that in 2010, there was a class action lawsuit in the United States against Dannon, which Dannon ultimately settled for $35 million. And the reason why is it was making untrue claims about the impact of its yogurt on the immune system. So they've changed the wording to make it less causative. And what I want to say is this particular yogurt is different than other yogurts, because this one does have probiotic strains added to it. So that is a probiotic yogurt. But anyway, I just point this out because remember, yogurt and probiotics are foods, essentially, and so food manufacturers have a tendency to want to make claims that may not actually yet be proven. So what about probiotics for general health? Because, you know, patients will say, okay, I've heard what you've had to say, but what about me just taking a probiotic because I want to make sure my gastrointestinal tract is healthy, or I'm hoping that it'll prevent something? And unfortunately, there have never been any studies that have shown that taking a probiotic is beneficial. It's not been shown to be beneficial for general health, longevity, or cancer prevention, but part of it is that these studies haven't been done. And so I don't want to say that there can't be any benefit, it's just that it has not really been proven. The other challenge is that we are not all the same. There is not just one bacterial community that constitutes a healthy one. There could be multiple different ones. And so there are differences among us, even if we're all healthy. If we were to analyze our bacterial communities in a lab, we would find that there would be significant differences. So it's not clear which probiotic strain may be the best for which person. What could be good for your sister could be very different for you. So again, we don't have any information to direct us as to what is the best probiotic strain. And so what I tell my patients is if you wish to take one, it's probably not going to be harmful to you, even though these things are not regulated. You do have to remember that. But the question is it really helpful for whatever reason you are taking it? So I have patients who tell me they want to take a probiotic because they believe that maybe it might have some impact on their symptom or whatever. And so I say, go ahead and take it every day for a month. But if it doesn't give you the effect that you're looking for after taking it every day for a month, then either move on to a different probiotic strain or don't take a probiotic. Eat a more healthy diet if you can. All right, I'm going to touch a little bit on fecal transplant. So what is fecal transplant? So fecal transplantation is a technique that is done with the intent of transferring stool from a healthy donor into a patient's colon to help restore gut microbial diversity. So what this means is that you have an individual, for whatever reason, they have been taking antibiotics, for example, and they have just not been able to get their diversity back, that we are going to try to give their colon a boost by repopulating it with the stool from a healthy donor, who presumably has a very diverse population. Well, we are doing this now routinely in medical practice for only one condition, and that is for people who have Clostridium difficile infection. This is a harmful organism that can cause a devastating diarrheal illness for people who contract it, particularly for individuals who are over the age of 65 who get it. So this is a very effective treatment. We can eradicate the Clostridium difficile infection by doing a fecal transplant in about 90% of individuals who go through this. So this was very exciting, of course, to the medical community and to many patients as well, which led to a lot of patients calling me on the phone, okay, this is so great, can you do a fecal transplant for me for my other diseases? And the answer is no. We don't have studies that have proven that fecal transplant is as effective as it is for Clostridium difficile infection. There have been some studies looking at fecal transplantation for individuals with ulcerative colitis, for example, but the efficacy is not the same as what it is for Clostridium difficile infection. And so it's really, really important that people understand that right now, that if you're going to have a fecal transplant for any other indication, it really should be done under a research protocol at a hospital. So how is fecal transplants actually done? Well, nowadays we actually have a vendor called Microbiome. This is a nonprofit organization based in Boston, Massachusetts. They actually have taken on the task of identifying healthy donors, screening them to make sure they don't have any infectious diseases, and harvesting their stool and deep freezing it, and then shipping it to hospitals that purchase it across the country. And so here at Johns Hopkins, we actually do that. We keep a freezer that has some nice frozen, freshly harvested stool that we keep in the freezer that we use for fecal transplant. Most fecal transplants that we do are done by colonoscopy, the same procedure that one would have for, screening for colon cancer. So it's very, easy to do. But now there is a movement to actually give the desiccated stool in oral capsules, believe it or not. And here's a picture showing you what the capsules look like. They are kept frozen until the time of use. There's 30 of them that you have to be able to swallow in 90 minutes. It's quite a big task. It's not quite as effective as doing it by colonoscopy, but nevertheless is an option for somebody who can't or is unable to go through colonoscopy. So unfortunately, with all the fascination of the gut microbiome and with the discussion of doing fecal transplant for recurrent C. difficile infection, there have been people who are now advertising on the internet, instructions as to how you can do it at home. And I really, really strongly advise not doing this because, getting a fecal transplant, we don't really know exactly what we could be possibly transmitting to you. And so I always caution my patients that, just like we gave blood transfusions 30 years ago, but we didn't realize that we gave a lot of people hepatitis C because we didn't know about hepatitis C, the same thing is true with fecal transplant, that we don't really know everything that we could be possibly transmitting to another individual. So unless the indication is so significant, this is a risk that really has to be taken into consideration. And in the United States, the only indication that our Food and Drug Administration will allow fecal transplant to occur in a clinical situation, again, is for recurrent C. difficile infection and not for any other indication. All right, I'm going to talk now a lot about diet because, and here, diet is really interesting because it's not just a way to treat intestinal dysbiosis, but it's probably the way to prevent it. So I'd like to talk a little bit more about that. So we are now understanding that our diets are really a prime shaper of our gut bacterial community. What we eat determines who's ultimately going to be living in our colons. This is showing that people who eat different kinds of diets are going to be populated by different kinds of organisms. So this was a study that showed that people who ate primarily a protein and fat-based diet had a predominance of a kind of bacteria called Bacteroides, whereas those who ate primarily a plant-based diet had a predominant family of bacteria called Probiotics. And so it's not to say one is better or worse than the other from a health perspective. It's to show that diet really shapes the bacteria that are actually going to live in your colon. I have really been focused on fiber lately. I have always known that fiber is really a great thing for us in our diets, primarily from a cardiovascular point of view. But I am really intrigued by this study that was published that showed that eating a very, very high diet, fiber diet, 55 grams of fiber that was typically found in the diet of rural South African men, was associated with decreased inflammatory markers in the colon as compared to ingesting a diet with 12 grams of fiber, which was typically found in the diets of African American men. This was an amazing study to me because they actually switched the diets in the two different populations that they studied and saw the changes in the inflammatory markers. And why this was also significant to me is that currently in the United States, our recommended daily intake for fiber is 25 grams for a woman and 30 grams for a man. And that's primarily based on research that is done in cardiovascular disease. So you can see that the fiber that is being eaten and consumed in South Africa is 55 grams, which is substantially higher than what I think most North Americans are really used to. The challenge with eating all this fiber, however, is as good as it is for the community of bacteria that are in our guts, unfortunately, it most likely will increase our gas because bacteria love to ferment fiber, and when they ferment fiber, they produce intestinal gas. So I always tell my patients, if you have a lot of gas, likely the bacteria in your colon are very, very happy. So what's available now? Patients always want to know, is it worthwhile for me to go get my microbiome sequenced? And you can actually do this now commercially, just like you can get your DNA sequenced. And so this is one company that is doing it. You can pay a different price, get more information. But the challenge we have is, okay, so now you've got a list of all these different kinds of bacteria in your gut. We're not able to predict whether or not you're going to develop a certain disease. We're not able to detect, you know, what's happening with you now. It's all very interesting information, but what we lack is research that tells us what we're supposed to do with this information. How should we act? Many more studies are needed. But what I envision one day is that what precision medicine will be all about is when you see your doctor, not only will they get a blood sample to sequence your DNA, but they may be asking you for a stool sample so that they can actually get your microbiome sequenced. But we'll only do that once we really know what to do with all the information that we're going to get. It's kind of similar to getting your DNA sequence. I don't know how many of you have actually done that. But sometimes, you know, you're told about how you have genes for all different kinds of things. And again, it's hard to know really what to do with that information. In fact, there was a lesson learned, as many of you may know, 23andMe, they faced a $5 million lawsuit days after being banned by the FDA, again, because they were implying that if you had a specific gene that was associated with disease, that this was somehow predictive. And what we know about DNA and genes is that just because you have a gene doesn't necessarily mean you're going to get the disease, even though you have the gene. There are other factors that impact whether or not that gene is going to get expressed. So we need more studies to guide us as to what we should do with this information. But all this information is fascinating. In the future, I think what's going to happen is that we're going to see a change in probiotic therapy. Ideally, in the United States, it would be great if our Food and Drug Administration or if some entity could ensure the quality and efficacy of these products prior to marketing and distribution. There have been numerous studies that have shown that if you analyze probiotic products that are on the market, that a significant percentage of them do not contain what the label says they contain, or they contain things that are not on the label. So what I also think that is going to happen is that we're going to see an emergence of probiotic cocktails. This is where selected probiotic strains will be put together, but with the intent of treating very specific medical conditions or symptoms. Right now, as probiotics come to market, they're not coming to market to treat any particular disease or symptom. They're just coming to market for general use. And, you know, we as consumers, we're fascinated. We're much more likely to buy a food that contains a probiotic, whether or not there's evidence it is actually beneficial to us, than perhaps a food that doesn't have a probiotic in it, which is why food marketers, they know this. That's why they charge you more if they add a probiotic to it. So what I would say, what you can do right now is pay attention to what you eat. If you're somebody who suffers with a lot of bloating and discomfort, maybe one approach would be to avoid eating foods that have a lot of nitrates. We know that if people eat a lot of nitrates, they cultivate a community of sulfate-reducing bacteria in their colons. And those bacteria, as they ferment the nitrates, produce a gas called hydrogen sulfide. And hydrogen sulfide on its own has been shown to increase bloating, increase the discomfort associated with bloating, and alter colon motility. So this is one way you can perhaps modulate your symptoms by looking at your diet. Another example of how food affects the bacteria and disease has come from a study that looked at red meat. We know that red meat contains certain elements in it, carnitine and choline, and if you eat a lot of red meat, you tend to cultivate a kind of bacteria called ruminococcus in your colon, and ruminococcus will convert the carnitine and choline into trimethylamine and into TMAO, and this product, TMAO, has been shown to be an independent risk factor for cardiovascular disease. So I know we all believe that eating a lot of red meat raised our cholesterol levels, but now we're seeing that eating a lot of red meat affects the kind of bacteria that you're going to have in your colon, which ultimately may in itself increase your risk for heart disease. So what makes the most sense to me right now? We're in a period of confusion. Well, actually, we're not really in confusion. We're just really at the beginning of a new frontier. People want to do something to change, but we don't really have a lot of information to guide us in a very predictable way. But what we do have information about is diet. And probably the best kind of diet out there, I believe, is the Mediterranean diet. I encourage people to eat a high fiber diet so that you get greater diversity in your gut microbial community. Many studies have shown this. The more fiber you eat, the more diversity you're going to have. The more gas you have too, unfortunately. Avoid taking antibiotics unless absolutely necessary. Yes, of course, if you have an infection, a documented infection, or an abscess, you've got to take antibiotics. But if it's something to prevent an infection, you really need to talk to your doctor about whether or not, how necessary it really is. Eat red meat, I would say at most once per week for many different health reasons, for your cholesterol, but also for the bacteria in your colon. Eat fermented foods only if you really like them, because there's no proof that eating a lot of them actually is more beneficial to you than not eating them. So, you know, I would say if you don't like the taste of sauerkraut, please don't force yourself to eat that every day. Maintain a healthy body weight, because it's true, if you are overweight or obese, that this does affect the community of bacteria in your colon. And so maintaining a healthy body weight is not just good for your bacterial community, but is also good for your body for other health reasons. And definitely don't eat too much. We tend to do a lot of that here in North America.
All right. Well, thank you so much, Dr. Lee. You're so passionate about this topic, and I know that we all have learned so much. Now, there have been a few questions submitted, and you did address some of the questions that were submitted previously. And now, in just one moment, I will go to the questions. I'm just going to discuss just briefly the long-standing relationship that we've had with Johns Hopkins Medicine International. Now, Medcan is the only Canadian healthcare partner selected by this renowned healthcare authority, and as part of this relationship, our Medcan physicians exchange knowledge and continuing medical education with Dr. Lee and her colleagues at the Johns Hopkins faculty. So if you are a Medcan client or someone who's curious and is experiencing a complex medical situation and could possibly value a broader view of treatment options, Medcan can facilitate a consultation with Johns Hopkins Medicine International, and many of the key benefits are listed here on the screen. So if you have any questions, please feel free to contact our Johns Hopkins Liaison Coordinator at the number 416-350-5956 or the email johnshopkins@medcan.com. All right, so Dr. Lee, are you ready for some questions?
I'm ready.
Okay, so the first question is regarding how the gut microbiome is altered after an obese person or patient undergoes gastric bypass surgery.
Yes, so there have been studies that have looked at this. There are definite alterations. Again, good or bad, hard to say. But a kind of intervention like that definitely impacts your gut bacterial community. For how long is not clear, but there are definite changes that do occur. And it also depends on the type of bariatric procedure that you have. There are differences.
Okay, thank you. Next question, do you see any connection between digestive dysfunction and AFib? If so, what triggers are apparent?
That's very interesting. I don't know specifically about digestive dysfunction, but I will say atrial fibrillation, which is an irregular heartbeat, which is sometimes associated with palpitations, for example, that has been associated with reflux symptoms. So I've had many patients, and it's been reported in the literature, that when they go into atrial fibrillation, they find that their reflux symptoms are worse. And reflux symptoms, I'm referring to heartburn and indigestion. I'm not aware of a relationship yet that has been identified between the gut microbiome and atrial fibrillation.
Okay. Thank you. What about any medical evidence for specific diets or how we treat our microbiome and its relation to autism?
Yeah, well, I had several slides talking about the role of diet. So we definitely know diet plays a role, but with regard to autism, I'm not aware of any studies that have linked specific things in the diet to the microbiome to autism. I think that's sort of the holy grail for everything. We understand that there is definitely a relationship between food and disease, And probably the link in between is going to be the microbiome and our immune systems and how they respond and interact with each other.
Well, that actually, Dr. Lee, leads to another question. Someone was asking, what are your thoughts about the gut and its health and mental health?
Oh, yeah, so absolutely. So there are studies that are showing that the state of our bacterial community can also reflect what our mental health is. And perhaps one of the most interesting studies that I read about in the past few years was done in an animal model where they took rodents and put them in a very stressful environment. And I know this sounds so terrible. I think one of the stressful things that they make rodents do is like swim, you know, as if in the poor animals become very, very anxious. So what these investigators did was, and they took the contents of their colons, which was basically the bacteria from the colons of these very anxious animals, and put them into the colons of animals that had been raised in a sterile environment. And what they saw was that the animals raised in the sterile environment now began to exhibit anxious behaviors. So this suggests that the bacteria in our gut somehow also affects our mood. And this is fascinating. Again, you know, that just shows the direction one way. What we don't know is in people who have depression or schizophrenia, we know that they have changes in their gut communities as well, but were those disorders actually caused by the changes in the gut bacterial communities, or did we see the changes because they have the disorders? So again, the chicken and egg thing, we don't know which one came first.
Right, yeah, I was reading a study about IBS and anxiety, and we just don't know what's coming first. So
right,
thank you.
exactly.
Well, we encourage people to keep looking online and perhaps reaching out to you. So I have another question, and it is quite specific. If PPIs, blockers, and lifestyle changes are not reducing GERD and esophagitis symptoms, what other treatments have been successful?
So there are other things that can treat reflux symptoms related to gastroesophageal reflux disease, as the writer indicated. So I would definitely look at lifestyle and look at diet. There are specific things in the diet that can make symptoms worse. These would include things like caffeine and a high-fat diet, because we know that these weaken the lower esophageal sphincter and allow reflux to more occur. If you are an individual who's overweight or obese, I would suggest investigating a weight loss program, because being overweight or being obese those are independent risk factors for having reflux symptoms. Now, in terms of managing the reflux symptoms, in addition to medical therapy using medications that reduce acid production, there are medications that can actually increase the tone of the lower esophageal sphincter. One of those is motilium or domperidone, and in the United States we have metoclopramide, otherwise known as Breglium. But in addition, depending on the severity of your reflux, you could actually look at acupuncture. There are small studies looking at refractory reflux in individuals who've already been on a proton pump inhibitor, still having symptoms, who underwent acupuncture and actually reported symptomatic improvement. And finally, I would say that if stress is a trigger for your reflux symptoms, you need to think about, explore ways on how to manage your stress. We know that the nerves in our gut are very responsive to our moods and our emotions, the hormones that get released from our brains when we are under a lot of duress. And it is not uncommon for somebody under a lot of duress to experience worse reflux symptoms. So finding ways to manage that stress is really important.
Okay, Dr. Lee. Well, we had some more questions. Do you have time for one more?
I can do one more.
All right, so this one is, someone has very high intolerance to lots of foods, over 88 foods, and they've been avoiding those foods, but even though they're focusing on plant-based foods and avoiding those foods, they're still experiencing digestive problems. I wonder if the advice you just gave about managing stress would be the right course, or should they be seeking, professional help beyond their food intolerance?
Yeah, I would definitely recommend professional help. I would say one of the, again, not really knowing the whole situation, yes, I think that stress could be a trigger for certain symptoms, but when somebody comes to me with that many food intolerances, first I want to know, like, how is intolerance being defined? What are the actual symptoms that we are discussing? I'm always worried when somebody has so many food intolerances that one of the things we're dealing with is a neurogastroenterology disorder. And so what I mean by that is that we have to recognize that our GI tracts simply aren't just one long tube where we pump food in and waste comes out at the end, but this whole thing has its own nervous system embedded in its wall. So we have a nervous system called the enteric nervous system with as many nerves in the wall of your gut as you do in your spinal cord, and yet this collection of nerves in the gut is distinct from the brain and the spinal cord. So often when people have so many different food intolerances, it's not so much the foods themselves that are causing the issue, it's that they have a disturbance in the nerves in the gut. And so we will see this in some individuals who have irritable bowel syndrome, where they have a whole constellation of symptoms. And it's true, certain foods can be, specific foods can be triggers, but there are some individuals that in that just the act of eating itself can create all kinds of symptoms. So I would suggest if you have that many food intolerances and you have digestive symptoms, that I hope you're working with a gastroenterologist.
Well, thank you so much, Dr. Lee. You've been so generous with your expertise and your passion, and we're so happy that we were able to collaborate with you today. I want to thank everyone who joined us this evening and wish you well, and hopefully we'll work with you again.
Thank you very much. Bye-bye.
Bye-bye.